I hope everyone had a chance to enjoy their tea or coffee, and welcome back to this first plenary session. We've heard a lot in the previous session around harm reduction in some of its quite broad applications, as well as in drugs. This session is really topic closest to my heart, and really in terms of we're looking at drugs, drug treatment and harm reduction in the 2020s. We've got an excellent panel of speakers who I'm going to provide a very short introduction to. We have Julia Rotsanova, who's an associate research scientist at the AIDS programme of Yale School of Medicine and also works at King's College London. We have Maria Prilitskaya, who's from Kazakhstan, assistant researcher at the Department of Personalised Medicine and Department of Public Health at Semi Medical University in Pavlodar. Amir Rashidov, who's a drug addiction clinician and in the Republican Specialised Scientific and Practical Drug Treatment Medical Center in Uzbekistan. Dr. Jing Du is a psychiatrist at Shanghai Mental Health Center with 20 years of experience in the drugs field. And a dear friend of mine, Dr. Kasia Kowalczuk, who is a lecturer at the University of Social Science and Humanities in Warsaw when she's not organising GPHN and city health events. So without further ado, if I could invite you up, Julia. Thanks. Can we just check, has the presentation been loaded on? Do we just advance? We have a clicker.
Okay. Oh, yeah.
So, and we're good to go.
All right. Perfect. Hi, good afternoon, everybody. Thank you so much for inviting me here, and it's always a pleasure to come to Bishkek. Thank you very much, David, for this very kind introduction. So I was going to share with you a few findings and learnings from a study that we have almost completed. It's in the very final stages of data collection follow-ups, and it's been probably 10 years almost in the making, that we conduct here in Kyrgyzstan in partnership with the AIDS Foundation East West. And here in the audience is my dear colleague Natalia Shumskaya, and a very big shout out to her and her team for their contributions. So how do I look? Okay. So first, I'll just share with you who my colleagues and my team are. I'll give you a little bit of a background why this topic is important. I'll tell you what we did and the methods we used. I will speak a little bit about the intervention, how we adapted it to the prison context where we conducted our study. And I'll share some preliminary evidence that we have from this work. And then there will be some conclusions that we will draw from there. Oops. Bear with me as I'm learning the technology. All right. So this is part of our team, and we are not very good in taking pictures, and partly it is because in prison context it's very difficult to take pictures while you are doing your research there. So that's one of the rare occasions where we were together and we remembered that it's important to capture those moments. And so here is our fieldwork team. And it's interesting to note that we have a split, it's like a co-ed team that goes into each prison to implement our study. And it consists of a person with lived experience of incarceration who is a man and currently working as an outreach specialist with non-governmental organizations. and a woman who is a psychologist by training and who contributed to the development of the training module that we were implementing in prisons. So I'm sure that you know already, and it has been mentioned in the previous sessions, that in Kyrgyzstan, in prisons, a lot of people are having a history of injection drug use. So the estimate is between 1/4 to 1/3 of prison population in Kyrgyzstan are people who inject drugs. And that means that they are not necessarily injecting drugs right at this moment, but they have a history of doing that. And because addiction is a chronic illness, there is always the danger of their relapse. And addiction is definitely linked, comorbid with HIV, and it increases risk of HIV for this population, to the extent that up to 11% of people in prisons have HIV, in contrast to under 1% in the community. So it's more than 10 times higher in prisons. However, 90% of prisoners do not have HIV, and we really want them to stay this way. And so initially, when the project was being conceived, we were thinking about reducing the risk of HIV as our primary goal. But as we went along, we kind of shifted in what we thought the primary goal was. And so we chose the instrument to do our work with prisoners as a peer-driven intervention, which is a task shifting technology where you put activities that are typically delivered by the healthcare workers onto peers, and in this case, they are prisoners themselves, who would be acting as health educators and coaches and providers of social support to their fellow prisoners, and who would be explaining to them the importance of healthy lifestyle, the importance of addiction treatment, and the importance of staying HIV-free. So this type of intervention, peer-driven intervention, is grounded in the theory of social control and social belonging, because the idea is that on one hand, peers have an in-depth knowledge of how to communicate with other people who have similar life circumstances. And on the other hand, they can create pressure and they can share certain values and goals that will create organic solidarity in the sense of belonging, but also a little bit of a kind of normative framework for people to follow. And the interesting part was that it's never been used in the prison setting. So it's very popular to use peer navigators in the community for HIV treatment, for substance use treatment. But in prisons, it's been less common. And so we were interested in adapting that to Kyrgyzstan and to, at this point, it was a clinical trial, but we were not trying to prove its effectiveness. We were looking at the feasibility, whether it was possible, culturally acceptable to conduct this work in prisons. So we had the approvals from the ethics boards of our respective organizations, and we used a process of adapting this evidence-based intervention to prison context through certain steps that we used. So the process itself involved quite a lot of work, because we read a lot of research that was published in other regions. And of course, it wasn't applicable to Kyrgyzstan, but also research that involved formally released prisoners was not applicable to prisons. And so we consulted with prisoners themselves. We had a number of qualitative interviews with them, and we also had some focus group discussions where we were asking about whether, first of all, addiction is something that they're interested in managing. And then if they feel that other people with whom they are incarcerated together play a role in the process. And then from there, we also had our own expert advisory group where we discussed the feedback that we received from our prisoner experts. And then we went to draft training module and an operation manual of exactly how we would be delivering our content to our prisoners and who would be doing that and what types of exercises we will do with them. And then we brought it back to our prison population, and we discussed that with them again. And so it kind of like was a recurring process. So we did at least twice like the cycle, and each time we refined our manual. And at the end, we had a product of 12 sessions and like a guidebook of how it is to be delivered by the training team. So that went live.
There's a slight delay. There's 2 seconds.
Got it. So hopefully it. Just trying to, oh yeah, here it is. So here there is a video clip that I'm not even sure if I will be able to play for you.
The subconscious part. Can we talk to each other without using verbal communication? Yes, it's possible. And that activates the lower part. So which part of this, which part of the iceberg should be more activated? The top, yeah, which is the logic. Now let's speak about the pyramid of needs and demands. It was invented by whom? By Maslow. Yes, that's right. What are the most essential needs of each person? The physiological ones like food, safety, the body temperature, hemostasis, so some comfortable physiological conditions.
So this was something that I wanted you to just kind of look at the dynamic of the behaviors of people. So to me, it was clear that they were having a very good time. So they were engaged, they were joking, they had a laugh. And those kinds of seminars were very similar to what I have with my students at university. And when you're looking at those participants, you don't think about that as a prison context, because it was a nice room and they had a really enjoyable time and they were talking about things that were important and meaningful. And I think that as we were going into that process, they took over the original plan of discussing with them things related to reduction of harm and motivating them to take up addiction treatment. So we switched that in our thinking that we have to be direct and target their addiction directly, to thinking that perhaps we should look at their mental health more broadly and holistically, think about their positive aspects of mental health related to goal and purpose in life, related to social support and resilience, and see if that is what can be modified, and if that is modified, then people will perhaps take care of their addiction better. And I will just, because I know that we are running out of time, I will show a few things that I believe are important here. So at the beginning, when we were starting with these participants, their mental health was very, very poor. So we had just under 100 people. And you remember that it's a feasibility study, so we did not want to prove that there was an effectiveness of our intervention. So it's more just to show that it can be done, but their mental health was very poor. So about 60% of our participants had moderate to severe depression. And then a lot of people had anxiety. So moderate anxiety was just under a quarter of them. However, a lot of them said that they do have social support while in prison, and that is significant. And I just received my colleagues' comments from my research assistant who's doing the calculations and analysis. So it's like just in, literally. And it's not in the slide, but we had a follow-up at 3 months and 6 months of what happens after they went through this training. And it looks like that people who were in the experimental prisons where they did receive the training, so their depressive symptoms were cut by half. So just under 30% had moderate to severe depression, and that is very, very significant, and it was statistically significant. And for anxiety, it was a smaller reduction. It was about like 1/3 of a reduction in anxiety symptoms, but still importantly. But the most interesting and fascinating thing for me was that the resilience went up. So for people in the experimental prisons that had this training I just showed to you, so the resilience score went from about 1.8 to 3.5, which is higher than the average resilience score for people generally in the world. So we found that because maybe they were, exposed to our intervention, but also perhaps for other reasons, it seems that their mental health was much better. And of course, longitudinally, we don't know if it will translate into them making better choices in terms of their addiction. But I think that there is a very good possibility that that will happen. And so just to conclude here, what we also know is that a lot of these people are using drugs. Many of them are using drugs while in prison. And they probably will keep doing that. But if they're going to be having better mental health, if their depression is going to be under control, if their anxiety is going to be under control, if they're going to have higher resilience, there is a better chance that they will be making healthy choices in terms of using syringes, if they're using drugs, in terms of maybe not doing the сочетанное употребление различных веществ, so the concurrent use of different substances and things like that. And I would like to just stop here. I would have the slides for you if you would like to ask me for those numbers. And so just to say that we believe that programs like that can be delivered. They're very labor intensive because a lot of work went into adapting this material. But now that we have it, we hope that it will be able to be brought to scale, and people in other prison facilities might be interested in trying something out, perhaps in other countries, in Kazakhstan and in other countries in Central Asia. And we are very much looking forward to discussing this material and to hearing questions. Thank you so much.
Thank you very much, Julia. Thank you very much, Julia. That was a very interesting and positive start to the session. And if I could ask Maria now to tell us a little about the epidemiological evaluation of novel psychoactive substances, please.
Добрый день, уважаемые коллеги. Пока мою презентацию загружают, я бы хотела сделать, прежде всего, поблагодарить участников конференции.
I would like to congratulate the participants and thank the participants for driving attention to these harm reduction technologies. And this is the first session in my practice of the narcologist, physician, and doctor that other specialties highlight the importance of tertiary and fourth level of prevention. And when we come to my presentation, I would like to present about the experience we present on one of the projects on very relevant issue for the oncology sector of Kazakhstan, the new psychoactive substances and synthetic drugs. And these two concepts will be interchangeable throughout my presentation. And we would like, my colleagues would insist to call it NPS, new psychoactive substances, but synthetic drugs and NPS will be interchangeably used throughout my presentation. And this is the general commitment, general statement that this presentation was done as part of the project financed by the Global Fund. Currently, I'm the participant of the SOLID project. First of all, before we proceed to the topic of our interest, synthetic drugs, about the young people, the brief remark about our background about the cases in Kazakhstan in 2009. We had the first reference to synthetic drugs in our country, and they were broadly covered in mass media. And this was not the government statement. The media and these are the institutes which alarmed about this issue. In 2011, there were some interventions to prevent the population from smoking spices and different substances. This was introduced as smoking mixtures, and in 2014 there were 27 new NPS, and there were new amendments to the law and supplements, and it is important to see what is going on at the market. And it was in 2013 when at the Republican Central Clinic we have seen such a client, and in 2014 we have some policy-related issues, some countering and combating this NPS, and there are new concepts in the law on the drugs, on narcotics. And in 2018, these activities and actions continue. We continue improving our legislation, and there were some desirable, non-desirable experience on countering this NPS. Kazakhstan was the first country in Central Asia on prohibition and banning NPS because of a range of issues and reasons. We came across this issue because of geopolitical reasons. And we have introduced in Kazakhstan the clinical protocol on diagnostic and the treatment of addiction of NPS. As a doctor narcologist, I can judge about the tip of the iceberg based on the patients. Maybe this is the subject of our pride. In Kazakhstan, we are trying to introduce the epidemiological surveillance and registration when it comes to NPS. It is not the part of the government reporting and recording system. This is a part of our practice for the last 10 years, and we can see there is the exponential growth of the clients which seek healthcare because of addiction to NPS. This is the phase or this part of the patients which would like to be treated, but they can't be treated, and maybe they already reached the severe phase of this disease. And as part of this research practices, through the grants, we try to engage the key groups of population in order to assess these new challenges. And we are interested about the key groups on synthetic drugs. These are the young people from 18 to 34 years of age. at the Republican Center, with the help of the UN, we have conducted the research on the use for the youth from 13 to 18 years of age, and these findings are quite accessible, widely accessible. And one of the recent studies to assess the awareness of the young people in terms of using NPS, we were reviewing the effects, the pathways of purchasing, buying this NPS, and some findings enabled us to see the challenges and issues and to highlight the regions with high rates of the NPS use. And throughout these years, we have touched upon all the issues, at all oblast centers and the cities of at the Republican level. And we have engaged with key groups of population to find out this was a street survey, and it was popular among the market researchers, but this was not popular for epidemiological survey. But this enabled us to find some randomized approaches to find about the practices among the young people, and we found out the points which are hazardous for young people, and where young people practice some unhealthy practices. And we provided the training, we provided the supervision, and there was a special control group, and we provided to all participants to information about the healthcare, and also the problems related to synthetic drugs or illicit drugs. This sample included 25% of respondents, and these samples were quota-based by regions and by gender desegregation. And as for regional social demographic profile, they were unemployed, those who are aware about the synthetic drugs. In other words, half of the respondents were aware, and instead of 3,000 during the first round of survey, the awareness was less than 30%. There is a growth of awareness, as we can see. And we talked about nicotine and other conventional drugs during the surveys, and we can see that we have problems not only with synthetic drugs, but this is a common practice among the young people. This practice intensifies for the age group from 25 to 35 years of age. Also, we had questions related to alcohol. As for the alcohol, the situation is even worse. The absolute majority are well aware of the alcohol. This is about beer. As for the narcotic drugs, the next slide, around 10% used drugs in their lifetime, and out of them, 10% and 4% used NPS. We had questions to sound in their slang to make it clear and understandable. Spices, synthetic salts, and we have selected these slang terms. This is quite an alarming sign, and the emphasis is on the age group 25-29 years of age. As for the structure of drugs, we can see that cannabis and sedative drugs, the sedative drugs are sold over the counter in prescribed drugs, which are sold in drugstores over the counter. And here you see different regions of Kazakhstan. And unlike this first round of surveys, of synthetic cannabis. Now, these are synthetic stimulators. We can see this on different billboards advertised in these regions. And this is quite alarming and risky situation. And we also asked the question for us to find out what is going on to the category, what kind of experience they have, and what kind of symptoms they experience at the time of using drug and post drug use. And these symptoms are maintained throughout 24 hours. And we have to think about harm reduction approaches and programs, and of course there are different NPS salts, intravenous, intramuscular injection, and this is similar to the surge of HIV infection among this group or of age group. And how to buy the patterns of buying NPS, and there are different ways of purchasing NPS, and this is quite easy. The easy access, this is anti-rating, the easy access to NPS in the cities where they can access NPS, Kokshetau, Pavlodar, Turkestan, Uralsk, Shymkent, where the respondents shared openly about the experience. And we asked about the costs on NPS. On spices, they spend not so much, but salts, stimulators, they spend a lot. And it speaks to the fact that from the very first moment they start spending a lot, and they start getting addicted. Also, we also asked another question, maybe sociologists will appreciate this. We have asked all the respondents, why do you think people tend to use NPS? And those who have experience and who don't have experience, this reasoning or incentives or motivation was diverse and different. This easy accessibility, and the people with experience, they say that they get addicted, they want to feel high and so on. When it comes to conclusion that in conventional NPS, there is a high share of young people which continue using tobacco, alcohol, and this is quite relevant. They can use it once a month or during the last month or during the last year. Cannabis use among the conventional opioids is quite common. As for synthetic, there is synthetic drugs, there is a decrease by 2 times. Synthetic stimulants are increasing in terms of their use among the young people, and fentanyls are also increasing. As for the patterns, conventional substances, unlike the synthetic, these conventional substances, use of conventional substances create risk factors for using NPS, and they can increase the use of NPS by 11 times. And we have to tackle the issue of NPS, the ways and patterns of purchasing NPS in Kazakhstan for Kazakh young people. They can be quite diverse and broad. The banning and prohibition are not enough. And we can see the toxic effects and implications which requires harm reduction interventions along with assessment of risk and healthcare interventions. Thank you very much.
Thank you very much, Maria. An important reminder of the value of research to know what drugs people are taking, which is sometimes we assume it's static and it doesn't change. I'd next like to invite Amir to come up and tell us about the work that they've been doing around the drug treatment situation in Uzbekistan.
Здравствуйте, уважаемые дамы и господа. Меня зовут, как представил до этого наш модератор, Амир Рашидов. Я представитель Республиканского специализированного научно-практического медицинского центра наркологии Узбекистан, а также являюсь участником проекта «Солид», благодаря которому я нахожусь здесь, могу находиться здесь. Сегодня я хотел бы представить вам
Today I would like to give the information to you about the narcolepsy situation in Uzbekistan. When I was preparing this presentation, I was surprised to some extent, in fact, and I shall try to show to you the changes taking place currently in our country. So the analysis of the narcolepsy situation for 2022 has shown that we have an increased number of addict patients compared to the previous years. On this graph, you can see, and I should specify that when say narcolepsy situation, but also in brackets, I say that these are the trends. This is not the absolute number of all drug users in Uzbekistan, because it's not enough to have the numbers from the registration database, but these are the estimates. And you can check the graph to understand the general trend. And at this slide, you can see, if you check the absolute number of those who are registered in the database with non-medical use, then we can see that there was certain decrease, and for the first time over the recent decade, we can see the gradual and stable decrease. But for the first time in 2022, we had to witness some increase. The share of women in the structure of the registered drug addicts, so over the years, was decreasing steadily, but then in 2022, the share of female PVIDs has increased as well. The narcolepsy situation and share of PVIDs and a breakdown by age groups from 19 to 38 years. So more or less it is stable with some variations, but over the recent year we again can see significant increase in the category of younger people. Most probably it is determined by the new influx of the young users of psychoactive substances. On this slide, we have numbers confirming again that those who are above 40 years, this group is increasing, so we're having more and more people in this age group, but over the recent years it has decreased. On this graph, we can see the structure in yellow or orange color. You can see those who are registered with service, those who use opiates, and green for cannabis. The proportion is more or less stable over the recent years, but before, cannabis was prevailing over opiates. On this graph,
наряду с тем, что
you can
происходит
see that
повышение числа
along with the
причин,
increased number
другие
of
группы
people who
наблюдается
use
также повышение числа
opium type drugs,
традиционных
but also we are
наркотиков,
having
то
increased
есть
number of
состоящих в общем да, вот, видно,
PVIDs, those who
динамики, что
inject drugs and who are registered with the
увеличилось за
database.
последние
You
даже
can
2
see that
года,
there is some
был
increasing trend,
наблюдается
but
рост количества.
it's happening more obviously over the recent years.
Случаи инфицирования ВИЧ
The
среди
HIV
потребителей инфекционных
infection
наркотиков
spread among
в 2022
the
году составил
PVIDs in
2,1%
2022 made
общего числа инфицированных.
2.1% out of the total number
За
of the
последние 2 года это
HIV
остается
cases
стабильным,
over the
а
recent
доля
2 years. This number is
ВИЧ-инфицированных
stable, and the
потребительств
number of
составляет 8,8.
HIV
По-моему, я слышал
PVIDs
такую же
makes
цифру
up
в
8.
Казахстане.
I think in Kazakhstan you've mentioned the same number.
Вместе с тем, как и предыдущий
At the same
докладчик
time, like the
отметил, во
previous
всем мире
speaker mentioned,
происходит
and this is a
и
global
происходит регистрация
trend,
случаев злоупотребления новыми видами
we are
лекарственных
having
веществ.
newly
Все случаи
psychoactive
злоупотребления
substances
синтетическими
used
каннабиноидами, а также
more and more,
синтетическими
and
каннабиноидами
cannabinoid times and
176, это в
Catinon
прошлом году было
176,
118.
and
И большинство из них были
although
зарегистрированы
last year
в
we had only
Ташкенте.
117, but
Ситуация связана с
and the
рецептурными
majority of
препаратами,
these episodes are registered in Tashkent
вычисляющим
city,
образом
and
и
with
являются
the
препаратами
drugs that are
составляют
dispensed
филевалин
according to the
и
prescriptions. So this is prenavalin and zapiclone. These are the products
обращаемость людей с зависимостью
which
от
are
рецептурных препаратов.
demanded, and that is this to show dependence on the
Прежде чем,
prescription-based
когда я
dispensed
подготавливал доклад, я
drugs.
все же
And when I was preparing this presentation, I was reflecting on a harm reduction strategy, and my question to myself was about the content and what interventions should be included, and different sources provided different information, but I tried to encapsulate all of them into one piece. So harm reduction includes also the development and the introduction of the national harm reduction programs to support PVIDs with different rehabilitation and social adaptation interventions. And in Uzbekistan, I should say, we have a separate body. This is the Analytical Center for Drug Control, and this is the coordinating body. This is the body which established the commission which develops the National Action Plan for Drug Control, and then these action plans are being implemented, and the expanded access for PVIDs to high quality services to do the diagnostics and treatment, including infectious diseases such as HIV, TB, and hepatitis, and also in access to the clean syringes and tools which are used for drug injecting. We have offices, friendly offices, and they are placed within the 8 centers where the harm reduction interventions are conducted, such as in a syringe and needle exchange, and also exchange of the international cooperation, and partnership is also one of the activities, and our event is one of the activities. And using mass media and educational programs to cover younger generations and young people. A lot of activities are conducted by the Ministry of Education and municipalities by involving religious agencies, let's say. The Ministry of Health is also one of the stakeholders. The drug monitoring is done in order to understand the scale of the narcomania.
Развитие
problem.
научных исследований,
And
изучение
also
множества
research
новых
activities
методов
are
лечения
conducted
профилактики
and the
наркомании.
new
То есть у нас только
methods
недавно
of treatment are
базе
being
республиканского центра
studied
сформировали
and
научно-практический центр,
examined.
где одна
Just
из целей –
recently, we
это
have
развитие и
established a
формирование
scientific and practical
научных
center
исследований.
to conduct scientific
И
research
формирование
activities,
межведомственных
and
комиссий,
also
которые,
interagency commissions are established.
как я до этого сказал, у нас
And
имеется
as I
национальный
said before,
координирующий
we
орган,
have the national coordination
который
body,
взаимодействует
which
и
interacts
формирует взаимодействие между
or
несколькими
helps
министерствами
to
и ведомствами.
interact between the different agencies and ministries.
Это я уже вам сказал.
This we can skip, it was
И
already
наркологическая
discussed.
помощь, я наконец
And
хотел
the
показать один
narcology
график.
care, here I would like to share with you one graph.
Гарантируется
So the
государством,
narcology
и
services are
обращаемость
guaranteed
за
by the
наркологической
state,
помощью
and
среди
the
наркозависимых тоже стало расти.
application
В 2022
rate from
году было снижение,
PVIDs
связанное
has
с
increased.
ограничениями,
Well, in
COVID и так далее.
2020 it was reduced because of the COVID, but in 21 and 22 we can see that again it is on rise. And what should be given the priority focus, because here we are discussing the activities to be promoted, and this is first of all to introduce the programs of social rehabilitation for PVIDs and social adaptation to return them to the public life, and also to develop the social work and to increase the skills and qualifications of social workers so that they can support the PVIDs more effectively, and also to involve more the NGO partners.
Спасибо большое за внимание.
Thank you very much. Yeah, and I think the point I particularly picked up on there was the importance of services that people feel able to go and use, the friendly services. A point we often overlook, I think. Could I now invite Dr. Jingdu to come up and give us her presentation? And it's very much building on the previous two, we're looking at novel psychoactive substances, but the drug treatment available in China.
Okay. Hello, everyone. I'm glad to be here to introduce a work of our program. I come from China and as a psychiatrist of Shanghai Mental Health Center. China, yeah. I think China is a mysterious country for all peoples. And I think some of them get the impression about China from the picture, like Monkey King and Peking Opera and the Great Wall. This is our city, Shanghai, my city. It's peer of the East China is a very modern city. The next year, this conference and our solid local conference will be held in Shanghai. So welcome. Okay, so this is part of our center's Department of Substance Use Treatment. This is a volunteer treatment center for substance use, including legal and illegal. We provide medical treatment and psychological treatment for them. We also provide training and teaching to the college and some staff in compulsory treatment center or the social worker. Okay, these slides show you the drug abuse in China. Now it's still a large number of drug use in China, although the growth rate. Why? The growth rate has decreased, but still a lot of drug users. The major abuse drugs are methamphetamine, heroin, and ketamine. About 1.48 million in China now. The abuse of synthetic drugs such as methamphetamine continues to increase, with 80% of newly discovered users abusing these drugs. Among the traditional drugs, for example, like heroin abuse showed decreased trend in our country. And people under 35 is the high-risk population for mass use. So the characteristic of synthetic drugs compared to the traditional drugs, these drugs prone to psychotic symptoms and a severe impairment of cognitive function, and easy to relapse and combined polysubstance abuse. Other issues now, there are no effective treatment drugs for this substance. And the population of users is mainly young and middle-aged people. This slide shows you the treatment, the policy of China about the drug prevention and intervention. Before 2007, the drug user was identified as offenders, only offenders. So for the government, we only provide the compulsory isolation treatment for them. But by the 2007, the implementation of drugs control law of the People's Republic of China, we defined the drug user as offenders and patients, both. So based on this law, we provide more medical treatment to them. They also can receive community detox for the first time arrested by policemen. But if they relapse in a community detoxification treatment, they will be sent to compulsory treatment center for 2 years. So this is a community recovery system in China. Before the patients relapse from the compulsory treatment to the community, the drug use patients and the social worker and the policemen, they will make a contract before they release from compulsory treatment center. Once the patient come back to the societies, they will be required to do urine test during the 3 years. And the social worker will provide social support to patients, including psychological counseling and employment and skill trainings. But if the urine test is positive, the patients will be sent to the compulsory treatment again. Now, a lot of study has confined the addiction is the chronic relapse brain disease. So based on this series, we did a lot of study to provide some treatment or intervention to the patients in our group. This is our group. This lady is our leader. Professor Min Zhao, she is very professional in this field. The middle picture is our center, is clinical center. Actually, we have 2 groups. One is for clinical work, other one is for the study, for the research, including the postdoc and the master degree student. And the right one is our campus. Very beautiful. This is one of our study. We based on the foundation, based on funding from the government. We did a longitudinal study. We established a large-scale clinical data and a biological sample bank. We include different stage of mass use and want to find the biomarker for early detection and diagnosis and relapse predictions. And we also developed some new intervention methods for the dependence. This is a multi-center study, so we include totally about 10 provinces in China. As we all know, there was no medicine for methamphetamine use. So we developed some non-medical treatment and intervention strategy, including CCAT, means computer-based cognitive attention recovery system. We also develop VR-based drug addiction assessment and recovery system. We also test the effective of TACS and TDCS and RTMS, like some neuromodulation effect in our study. So we also did try to collect some data and explore the data effect of this intervention and publish the articles on the journal. So this study identified RTMS could reduce craving and improve cognitive among ATS users. They also identified the functional connective change after RTMS intervention. This one is a computer-based cognitive addiction therapies, because most of ATSUs, they have a cognitive impairment. So we developed this CCAT and help them to improve their cognitive function. So this is the outline. Is include intervention training model, totally 5 training models, including working memory and cognitive bias and attention function. And after the intervention, the management platform will show some data to the doctors. And based on the results, we can modify the training schedule. This is CCAT. This is based, it's a target for ATS use. As is a study, we also published this study on the journal. This is VR intervention in our group. We developed, we worked with company and developed this intervention, and also targets for the ATS use. We use VR to induce their craving and provide training or intervention based on the craving stage. Oh, it's what we did yesterday. Oh, we showed yesterday. It's AI intervention. This one is AI intervention, addiction rehabilitation therapist. Because during the COVID-19, we know we cannot provide training, provide intervention to the patients, even in compulsory treatment. So we may use AI to provide intervention to them. Based on exactly this, we also provide group music therapies and mindfulness-based intervention to the patients. This is a training program. As I mentioned before, we also provide training to the compulsory treatment staff and the social worker. It's a role model for the for them. It's time. Okay. I will show you something. It's time. Okay. We developed some popular science education for the public. Okay, this one shows some NPS because in China, new psychoactive substance was not forbidden by the government, so we don't have enough sample to do some study. There are some case reports. The most popular use is marijuana and novel benzodiazepines. For this, in order to address these issues, the government implement comprehensive classification and control of synthetic cannabis and fentanyls. By the end of last year, the number of narcotic drugs and psychotropic substances under control in China reached more than 400. We also have some other substance use in the young kids. For example, like this one, laughing gas. I don't know how about it here, but in our country, lot of young kids use this one. This is a young boy from outside, from overseas. He is studying in the outside. And after 2 weeks treatment, the patient's emotion was stable and no some psychosis. There's no some psychosis. This one is treatment for 50 days. He can do some exercise. This is also for the young ladies in China. For girls or young lady, they use ATS to lose weight, but they don't know it's a drug, so they use it for the lose weight. This is also used in the young teenagers. For some medicine, you know, the Ritalin for ADHD. So in China, some students use it to improve their study abilities. Okay, the last slide. To deal with these issues in the world, I think the policymakers, researchers, and doctors and staff from schools, social workers, we need to work together to control the drug use. Okay, thank you.
Thank you very much. And you managed to get a huge amount into your presentation and introduced me to some treatment approaches I hadn't heard of before. So that was particularly interesting. I'd now like to invite Kasia to come up and provide us with an overview of harm reduction in Poland and the challenges and opportunities that there are there.
Thank you, Dave. I'm gonna try to be brief because I know we are running out of time and also all of you are tired. I think that being Polish sort of gives me permission to show you a little and to tell you a little bit about the state of harm reduction, drug prevalence, and general public health problems in my country. Just a year ago, we were celebrating a 30th anniversary of establishing a first methadone program in Warsaw. And believe me that back then, it was a very brave action in that part of region. But it seems that when you look over the past 30 years, we just lost this bravery. Harm reduction is understood as even a set of tools aiming at minimalizing risky behaviors is not widely acknowledged, is not widely accepted in Poland. It's not only a pity, it's just a mischance, because we know that harm reduction works and its application goes way beyond drugs. So let me just start with providing you with some data. And for the purpose of this conference, I put the data for a country that representatives are here in this room. So the data comes from a sort of a Bible of people who are interested in harm reduction. Each year we are waiting for the report on the state of global harm reduction. So I was quite surprised to find out that my country is not doing well. I knew that we are not doing well, but in here, what you can see, and I'm happy to share this presentation, are some core harm reduction actions that you could find in different countries. Germany seems to be the leader of my table, at least. Although there is one slide in which I wanted to show you also that Germany also struggles with other problems. But Kyrgyzstan is doing far better than Poland. So one thing that I know is happening right now, we are finally, after a couple of years, having a pilot program on naloxone, take-home naloxone. And I know how much problematic it was to start this program. We just couldn't find doctors who would like to prescribe naloxone. With regards to psychoactive substance use, it seems that drugs are not our key problem anymore. So the average of substance use in Poland is beyond European Union average. The most popular drug is cannabis. And as you can see, cannabis and opioids are not that popular. But I would like to elaborate a little bit more about what my colleagues also said in their presentations about new psychoactive substances. That was a huge thing, especially a couple of years ago. So it all started around the year 2008. Plenty of shops, online shops and smart shops were open, where especially they were targeted at young kids. They could buy different substances. And it lies well with what Maria said. Our government also tried to fight this problem. So the very first thing they did was they put another substances in the list, in the catalog, which didn't work. Yeah. The response of the market was that once there were some other substances in the catalog that became prohibited, they started to create new psychoactive substances from different ingredients. And then in 2010, what happened was, and that was quite illegal, not quite, that was illegal. So our Ministry of Health started an action in which they closed more than 1,300 shops selling new psychoactive substances. And it's reflected in the data that we faced a drop in poisoning, but it didn't work. It didn't work, and the most problematic year is the year 2015, when the numbers plummet. So our government this time, took it more seriously and perhaps put more thought into it. And they amended a bill, thanks to which since 2018, the numbers started to drop. So one of the things they did is the time that was needed to put new substances into the catalog, into the list, was much shorter, which helped us a lot. They also redefined the new psychoactive substances. So thanks to this clarification, it was just easier for us to fight with this problem. But as I said, if you would ask me, what is the biggest problem? We have far many others. What are Polish people dying of? Well, there are three key reasons: cardiovascular diseases, cancer diseases, and respiratory diseases. And the actions that contributes to that are, of course, smoking and drinking alcohol. By the way, alcohol in Poland is the most popular psychoactive substance. I highlighted here in red, although I'm not sure if it's visible, also our colleague from Germany. So in our countries, the prevalence of smoking women seems to be high, especially as we are looking at the other countries. What I want to highlight and emphasize is that harm reduction has already tools that could help people with smoking or with alcoholism. There is tobacco or nicotine harm reduction. So we already have tools that could help people who cannot smoke, that could help us save lives. But as I said, it's not widely acknowledged. With regards to alcohol, I have heard rumors that finally in Poland, the first managed alcohol program will be open in Gdańsk, in which people who cannot quit drinking will be served, of course, monitored by doctors with a small sample size of alcohol. However, if you would ask me, what is the biggest problem of Polish nation? I would say mental health. Mental health is something that we are challenged the most, and of course, mental health and substance use are linked with each other. Yeah? We know that oftentimes people who are representing key populations, they do struggle with mental health. The data that you see on the screen are pre-pandemic data. Right now, it's far worse, and those pre-pandemic data tells you that at least almost 1/4 of Polish people, and there is like 38 million of us, has suffered at least from one mental health disorder. Well, that's just scary, so to say. And I don't have time to elaborate on this more, but one of the biggest problems we are facing is mental health of kids and teenagers, given that we are absolutely lacking of psychiatrists working with this group. So, a couple of months ago, I had the pleasure to participate in a project in which we were asked to assess the access to different types of treatments for people who use drugs. Drug-related treatment, but also mental health services. And here you can see some of the findings that we came across. Well, first of all, and well, I'm not surprised being born and working in Poland, there is a dominance of abstinent approach. There's really little room for the harm reduction. But this is also linked with the stigma. So stigma for people who use drugs, this is a topic which is well known, but I was so surprised to hear that majority of stigma comes from service providers, comes from doctors who prescribe methadone, for example. And we've heard so many stories in our interviews that it's just scary. And the other day I was with Maria in a taxi, and we are also discussing this topic, because in Kazakhstan it also seemed to be a problem. The other things are more logistic based. So in Poland, we have 16 voivodeships. So Poland is divided into 16 regions, and some of the regions are absolutely not covered with any types of services. There are 2 voivodeships without methadone problems, while we are having 6 in Warsaw. So to wrap up, what I would like to say is that I think from the Polish perspective that we are missing the opportunity of using harm reduction, given that it goes way beyond beyond drugs. And the reason for this is that, unfortunately, the political climate in Poland is not in favor of, I think they're doing more harm than good. In November, we will have parliamentary elections, and the party that is ruling right now most likely will win. And what they do in the past years, they cut off fundings for harm reduction services. So this is the most likely direction we will face. Also, one of the things that is, I think, worth highlighting is, in general, lack of knowledge about harm reduction. So in our country, if you want to work with people who use drugs, one of the options is to become an addiction therapist. And so you spend 5 additional years when they teach you how to do it. And in their programs, there's maybe, out of 5 years, maybe 4 hours dedicated to harm reduction. So right now I feel myself like some sort of pioneer because I am a lecturer and I'm teaching students at the faculty, at the students of psychology, a subject called harm reduction. And then again, I would like to finish on a more like positive note. So one comment to mental health is that right now, Poland is in the process of, we are in the middle of mental health system reform. It started 2018, and the idea is to move from the asylum type of providing services. And the idea is to open a couple hundreds of centers. They are being called Centra Zdrowia Publicznego, so centers for mental health, in which people will get access, fast access to services, to complex services, that being psychiatrist, psychologist, social worker. So we are in the middle. The data look promising, but the whole process will end within like 4 years. So we can't elaborate much on this. Thank you.
Thank you very much, Kasia, and I certainly, yes, the courage in leadership benefits are something I can certainly recognise in a UK context. We have a time for a couple of questions. If people would like to introduce themselves and direct their questions. We have no, oh, there's a question at the back. I can.
I have a question to our Uzbek colleague, narcologist. I would like to ask you, you mentioned about the harm reduction programs. Maybe I didn't hear well, maybe you didn't say anything about the, did you have the Ubriharmin, buprenorphine based harm reduction program? If you remember back in time, we had Central Asian Harm Reduction Center in Uzbekistan, Tatiana Nikitina, and they implemented some activities when they were writing the document harm reduction program in the context of totalitarian regimes. And I am keen to hear about the programs which worked remotely in the center, in the capitals. There were some activities when you go farther from the capital in the regions. Do you still maintain and operate this program? There was a remote management and control and supervision. Was this program extended? Have you ever heard about this program? I have a question to all speakers. The topics and presentations were very interesting. I have a question to our colleague in China. Our Chinese colleagues are doing amazing job. If they decide opt to do something, they do it brilliantly well. And some years ago, they came to provide technical assistance and learn lessons from us about this Central Asian experience of methadone substitution therapy. Your country is quite huge, and how quickly you have implemented and introduced substitution therapies. These substitution therapies, are they progressing this same the same level, the same scope? And I have a question to the speaker from US on the prison system. In Central Asia, as you are well aware, one of the best programs on harm reduction, one of the countries we started syringe and needle and syringe exchange programs, NSPs. They started at the very beginning. We were not explicitly saying that we are leading these NSPs, and we have this Atlantis, Clean Zone, and the NSP points. And I'm so much pleased that Margarita Sabirova, who graduated our harm reduction programs, and she's implementing such nice, amazing programs. So how this program will interact with the prison program and the programs outside the prison, resocialization and social support program. I'm sorry for raising so many questions, but I'm very much keen to hear the answers. As for the substitution therapy in the Republic of Uzbekistan, this is not in place. Back in time, it was a pilot program. It was in 2009, and since then, the substitution therapy was ended in the Republic of Uzbekistan. Tatiana Sergeyevna, Nikitina, she continues working in NGOs. I don't have the correct answer with regard to your request, your question. I will follow this up on my side.
Yes, in China, we also use methadone maintenance treatment. We also use methadone substitute treatment in a volunteer treatment center. Yes, we did study in the methadone maintenance treatment clinic. We find the number of patients decreased during the last 10 years. The reasons including some heroin user transferred to the ATS mass users, and other reasons including some patients died, heroin use died. In the clinical methadone maintenance treatment clinical, except provide methadones, we also provide some intervention, like for example, we will tell them how to reduce the risk factor for HIV and HCV infections. We also do some brief intervention in the clinic and help them to reduce alcohol use. That's all.
Спасибо большое за ваш вопрос. Я по-русски.
Thank you very much for your question. I'm going to respond in Russian. I think it is more convenient for the Russian-speaking colleagues. I am the researcher. I don't know about the policymakers and practitioners who will follow up this program in terms of financing these programs and the recruitment of staff and so on. And on my part as a researcher, we can provide more competent point of view or opinion about the efficiency of this work. As for the alternative options, how they can be compared with each other, and the decision makers, the policy makers, to have the full set of information and data to inform their decision. As our colleagues mentioned and pointed out, there are lots of priorities which compete with this issue. There are too many areas and fields, letting alone other public problems, including narcolepsy, which require our close attention. And there is a danger that this attention will switch from harm reduction program, as Kasia mentioned, to some other priorities. And moreover, these programs are energy intensive. They are not pinpointing programs. They have to be implemented in a comprehensive manner, and then they will generate better impact. This is not the cumulative effect of individual programs, but they enable to implement more programs to address social and other issues. I like retrospectively, I can say this approach should be combined with the innovative approaches Chinese colleagues mentioned about the artificial intelligence, and people would come to the group and they communicate with the other participants. And we have tested NSP needle syringe programs and the methadone therapy points for all these programs to be should be implemented as a whole in a holistic manner. As a researcher, I can provide and offer this information to at different powerful platforms and spaces for all decision makers to be able to hear about this, and then maybe they will go for following this up on their own. Maybe we need your help and assistance. And of course, individually, we cannot combat this problem. We have to unite our efforts. Thank you very much.
Thank you very much.
And then I'll let people go to lunch.
Меня зовут Александр Залещенко. Я
My name is Alexander Zelichenko. I represent the Central Asian Drug Policy Center. I am engaged in drug policy since a long time ago, and the session was amazing, interesting, and lots of interesting topics. I wanted to find out, to understand why none of the speakers mentioned about the role of the police. Without this, it is impossible to promote the harm reduction programs. We started with the engagement of the police 30 years ago. We are getting back to this approach, to this practice. So I wanted to hear some innovative approaches in terms of engaging with the police. Of course, we had a lot ahead of us. Maria, thank you very much for a very interesting presentation. For the first time, I have heard about the status of NPS in the country. The information is so much scattered and sporadic, and you have provided such well-structured information. Are you going to promote these interventions? Are you going to address these issues at some spaces or platforms? And no one is providing any recommendation, no police, no doctors. When it comes to prevention, we cannot find any information about this. The same question to Julia about penitentiary system. What is next? Are there any next steps? We have achieved something. We have stopped at some point. Then we cannot advance further. We don't have any leverages anymore. We don't have any tools left in our disposal.
I'm tempted to start talking about the UK experience, and I think that topic would be enough for a session on its own. I don't know if you have short responses, and I think that would be a good topic that I'd like to explore further. And,
my reply would be, so if the two of you could meet at the lunch and discuss, as Dave is quite of an expert in what you just asked about. So my response will be, sit with Dave.
I can't take any more questions because we are out of time. I'm sorry, we're over time. And I'm very conscious of trying to stop people getting their lunch. It's often a very unproductive experience. But you can follow up with speakers over lunch or over the next 2 days. I'd like you to join me in thanking the speakers and for those who helped make the technology work, people who made sure people got the microphones, the translators have done a wonderful job. Thank you very much, and I look forward to seeing everyone back here at 3 o'clock.